all. On behalf of the TNISG, we welcome all for this extraordinary meeting. You know, the second anniversary of our journal, GHEB Journal, which has become more popular now. And I'm here standing on behalf of our President, Dr. Venkatakrishnan Sir, who is in Trichy and is not able to come today due to some previous commitment. It's a very happy occasion for us to celebrate this function today. Now I'll ask our Editor Emeritus, KRP Sir, to start the proceedings.
Good evening, and I welcome you all on behalf of TNISG and Tamil Nadu Gastroenterology Trust. And I think I should thank Professor Ramakrishnan, all those whose initiative the whole thing started, this journal. And of course, Dr. Bala was a very backbone of this sort of initiation. And it's all happening because of the collective effort of Dr. Bala, Dr. Ubbal, and Dr. Ramakrishnan. So I'm just only a figurehead. So I would like to thank and hard work by Dr. Rama. Yes. So Dr. Ipan, I would like to thank everybody. And with all the effort, I think now we are completing almost 2 years now. 2 years, and the journal really sort of has got a good impact, and it's read widely, and it's got a wide appreciation. I would like to thank once again everybody who's involved in the sort of creation and conduct of the journal. So I would like to hand over to Dr. Bal.
So we are supposed to start at 6 o'clock because there is so much traffic and we are delayed. I request our Editor-in-Chief, Professor Ramakrishna, to come over and speak about a few words. Maybe after that, I'll request some of the editorial board members to give their suggestion. So the main idea of this editorial board meeting is we are able to achieve whatever for the last 2 years. And the way go forward, what we are going to do, that is our main focus of discussion for today's editorial board. I request BSR.
Thank you, Bob. So I think we heard about the formation. I think Dr. Ipan and Ubal had discussions, and then they formed this journal. They kind of persuaded me to take on as editor. And thanks to Dr. Padisabi and Dr. Bala, who agreed to take on this journal as part of the Tamil Nadu Gastroenterology Trust. The parent ISG did not want state chapters to start their own journals. And so that is part of the background behind this. So we started with 4 issues per year. And so far we've been publishing on time. So one of the things that I learned from when I was an editor of the Indian Journal of Gastroenterology was that your ratings depend a lot on whether you publish on time. I mean, if you publish your January issue, January next year, then obviously you're going to be very badly rated. Whereas you publish in January, it's the indexing companies, the people who do the indexing, look at it as something which is good. So that's one thing that we've tried to do. So let me tell you what my strategy was. That initially was to try, the first is that we should be all inclusive, and I'm hoping that all the members of the society will contribute reviews, original articles, case reports, everything. And the idea was to be inclusive as far as that is concerned. The second thing was to publish on time, and we maintain a reasonable quality in terms of the language and everything. So we've been relatively fortunate that way. What we've not been so fortunate with is that we're not getting a lot of original articles and reviews. So going forward, we will be completing 2 years in December. And so from the third year, we were hoping that we could index the journal, that is, get it into PubMed, because that is the first step in getting more international recognition. We have got a couple of people from abroad, from outside the country, who've submitted papers, but it really needs to become more. There is also attention in the sense that every now and then I get an email saying, would you like to sell the journal? So I don't think we've reached that yet, but it tells us that people are looking at the journal, they're looking at the name, and that it has a kind of positive view. So going forward, as I said, for indexing, the first step is to go into what is called the Directory of Open Access Journals, or DOAJ. And for the DOAJ, we have some criteria that need to be met. One of the things that we may have to do is to relook at the editorial board and then make it a little more wieldy in terms of this thing. We need to have more original articles and we need to have more reviews. They don't count case reports. They count original articles and reviews. So I'm requesting all of you to send reviews. It should be easy. I mean, if you've had students, they've all reviewed something for their thesis, just take the review of their literature, and it doesn't take too much effort to put it together into something. I must say that my first DRNB student from here, Rohan, in his thesis, that review of it he wrote and sent it to the Japanese journal, which is the hepatology research. And without quibbling, they have accepted it. So I think we all need to do this. And I look forward to your support in this endeavor. So I think it might take another year. We're hoping to do it by the end of the second year, but I think it might take another year for us to get enough original articles and reviews published so that we can then get the DOAJ. I think we meet all the other criteria which are there.
I request Epan, who is always have a lot of ideas and suggestions to improve not only journal, and he's one of the brain behind for all the meetings, innovations, and research in TNISG. Everything goes to Professor Epan. I request Epan to his suggestion.
Thank you, Bill. First of all, I must say that with everyone here together, I also feel equally proud that I can join this event today. Surely it is a good landmark in the journey of this journal and for our society. It is good to have the journal. It's bound to have positive effects for the future, for the next generations. So that makes me proud, as all of us here are. And let me again acknowledge Dr. Rama, Ubal, Dr. KRP sir and Dr. Bala for their guidance in this whole endeavor. There are two particular points I would like to highlight, and one little radical thought to think about. The first is, to me, what fills my heart with joy is the fact that this has impacted the rodenticide management in Tamil Nadu. So the moment we put out the guidelines on management of rodenticide, within 6 weeks it was picked up by National Health Mission, and government funds were allocated as well as attentions were drawn to the problem. And what was proposed, that in each district there should be a hub and spoke model, etc. Within 6 weeks it got enacted. So this across Tamil Nadu study, which we did in 2019, was first sent to the Australian JGH journal and was turned down. It is a big problem for our state. And once we had the journal, we could very easily bring it out. And that impacted the government policy. So that is a very clear example of how this has already started yielding fruit, which is beyond what we have. So first idea I have to propose is what Dr. Jayanti said. Would it be possible for, in some manner to have an IRB ethics committee formed. I don't know, is it under the journal or is it under Tamil Nadu ISG or in some manner? Big hospitals have their own IRBs, but maybe smaller private hospitals, as well as the government hospitals, medical colleges and hospitals, it may enable more of this to happen. So we should think about it. It's not, Ubal was saying that there are various steps we have to go through it, but it's not really a journal question, but it may add to the process. The second is a more radical thought, which I will have to make a small presentation about. I feel there's a big racket in this medical journal business. I'll give the example of, but a formal PowerPoint will come separately. Let me take the example of Lancet. To submit an article to Lancet costs £3,000. £3,000. So just imagine. To get an article to read in Lancet, we have to again pay pounds. So the guy who's writing is also paying pounds, and who's reading is also taking pounds out. Now, who's taking the money now? So it's all there in Wikipedia. If you do some research, you can get it. It's owned by the publishing house is owned by one family in Germany. One family in Germany is owning it. Is it profitable or not? In the last 10 years or so, Lancet has now started almost 20 new subspecialty journals. So evidently it's highly profitable. The Lancet Gastroenterology, Hepatology, Lancet Infectious Diseases, Lancet's on something or the other. So this is almost like morally wrong. It's almost like that. So I see the need is for a publishing house. The need was earlier for a journal, which we have. So this is a radical thought. So you'll have to allow me another opportunity to make one little presentation. I will convince the idea about it, and it needs all of our input to think about it. But the first comment is it's wrong right now. So and we can start one small model here. The idea which I have to present with, but you'll have to wait for the next PPT for that, is an IPL model. Cricket earlier was controlled by everything in London. We are all running there too. Now suddenly India has become the powerhouse for cricket in that format. It's some other model, business model. So we have to, it's possible, I think. But we have to evolve. At the same time, it should be morally correct. It should be morally, ethically correct. That's my proposal. So let me conclude by appreciating the journals where we've reached. It's very nice. And to move ahead. Thank you.
Thank you, sir. And among the editorial members, we always choose, we pinpointed certain people so that there will be future editors-in-chief, because we cannot trouble Professor BSR forever for editor-in-chief. There is one person, is Dr. Paramanayam. I request Parama to give his opinion and suggestion. He's one of the potential editor-in-chief in the future. Epan is the one, and
Thank you, sir. I'm too young or too naive to be thinking of editor-in-chief. I'm not yet written much. But as sir has just echoed now, but there are some recent thoughts. I think there have been some papers also which says that, see, this current process of editing and publishing is possibly not the best way to go forward. There have been thoughts about what we see. There is not only the publishing house which takes it, but there are a lot of negative articles which are not there or not actually getting published. So there's been some loud thoughts about whether all the papers which get submitted to a journal should get into the print, and whatever the reviewer has to say, whether that should also be put forward in an online model and see. That is the way I think we will get more scientific content coming up and see what what the reviewers think and how to go about. I think that's what I had read about a couple of weeks ahead, and I thought that was an interesting thought, but I never thought that would come to this forum. I'll try and, I've been given an opportunity to write a review, which I'm doing right now. Probably I'll try and contribute more to this journal in the next year as well. Thank you so much, sir.
I think only few editorial board members are here. I request Professor Bhanumati Ramakrishna to speak a few words.
Good evening, everybody. I didn't expect you will ask me to speak. I think definitely the journal is doing very well, not because my husband is looking after it, but I think a lot of enthusiasm about starting it and taking it up. I think, like he said, we should submit more of original articles and review articles so that the impact factor will go up. And also, I feel though I am very interested in writing a lot of things, I find a lot of people are not interested, even in hospital, maybe even in medical college also. I mean, CMC also, not everybody is interested in publishing or even their thesis. There's so many students are there now. Compared to our days, there are a lot of PGs are taken up on every course. I think we should make, I think in CMC, they brought it up once, but I'm not sure the publication is still there. You should make them to publish, then only the good work will come out. That we should encourage somehow to ask them to publish. And also corporate hospital also, like I'm working in a corporate hospital, we have lots of series of things. It may not be anything in novel ideas, but whatever you have, I keep telling the junior faculty and all that to write up, and then so that you know what is it'll be different because you are seeing a different kinds of patients here compared to CMC, a lot of international. So many things the ideas can come out. But I think the younger generation, what I feel in my areas, not very interested in writing or publishing. First, I tell them to start, at least write the case report. Then they can progress. That's the way we all did. Your thesis first you write, then you can pick up how to write a paper. And probably you can conduct some workshops and all that like last time, so that people can be interested in writing, so that the original articles, if it comes out, a good article comes out in the journal, definitely the journal impact factor will go up. Like I think we are also writing some review articles so that we can boost up. I think everybody should, and also a lot of reviewers should be there. When you send an article, they should review it fast. I don't know, I think Indian Journal of Gastroenterology, Dr. Shobha and all there, she used to send me anything pathology. She said, you are the first person, you are sending it within 24 hours or 48 hours or something. Because I always feel when you submit an article, sometimes you wait for months and years to get the feedback from the journal. I think we should have the stipulated time, we should finish it and then submit, and also encourage the junior faculty to write more papers and submit, at least their thesis they can submit, write a paper, so that the impact factor will go up and the journal will pick up. And it's really a good work you're all doing, and thanks for including me as part of your, one of the editorial member for this, to at least access the pathology part of it. Thank you.
Good evening, all. First of all, I would like to thank our ISG for starting this journal. My professor Jayanti Madam used to say always, either you publish or perish. Actually, in our government setup, we have a lot of patients and a lot of materials also. Now we encourage our postgraduates to do that, and this is actually very useful for us. So I congratulate our ISG for this second anniversary. Thank you all.
Good evening, all of you. As Professor Ramakrishna said, that in the third year onwards, we will aim at indexing the journal. We are moving towards that, and we have brought out 8 issues. And request is we can have a special issue on a single topic. That will be a good idea to have in addition to that. And when I go through the PBG, they have more than 250 reviewers. We can increase the review pool, and reviewers are good potential authors also, so that we will get more. These are few suggestions. Thank you.
Good evening, everybody. I think in the World Cup time, previously, one small thinking, journal means we are very afraid actually, whether our journal will be accepted. Later on, we are forced to write journals. We are forced our PhD to write journals because it becomes mandatory for the MGR University. Thanks to pioneer efforts by Professor BSR, it has become a nice art. Publish or perish was a mantra, but not all published are good. You have to check the chaff out of it, and negative also is a good part. I won't say negative is a bad thing. I'm a basically negative person. I'm a pessimistic person. I rarely get disappointed in life. So negative thinking also is good in a part of way. And I welcome Professor Ratnaswamy. We should have a special things. We had a single team conference on hepatic encephalopathy, which was conducted in Indore in 2005. It was a benchmark papers where we used to have the your dosage of the any fits in encephalopathy. We had some drugs also. First time we came to know about the drugs, how to give the drugs, and all those previously used to have depressed patients. Now I can't. So similar things, hepatic. We have so many topics. Leave alone Baccheri, something else more than Baccheri. So many pathology topics are there. And new the COVID and liver, that is can be a new things. And it is growing. It is become indexed. I am very happy. It was not started during my time as a president. I wish the electoral, I was a member, but I wish the Tamil Nadu IST to become the most important indexed journal in the entire world. Wish all the best. Thank you.
I just wanted to say one thing in light of what people were saying. This is just to let you know that the most cited articles anywhere are review articles, not original papers. So please, all of you submit reviews.
I don't have much experience in editorial board and editorial. I can read the journal. I can understand pros and cons of the journal. I publish very few papers, which was accepted in the journals. But I don't have much experience. So, but this is a good initiative. They are doing wonderfully well. Thank you very much.
I request any other senior members, postgraduates, any suggestion for the journals?
First of all, many congratulations. I think we are one of the only association with our own journal. I think all over India, and I think that credit goes to the Tamil Nadu ISG, especially Ramakrishna sir, Ubal for his perseverance and all the support. I think congratulations again. I think it will grow. It will grow. Period of time. Then I also agree with Professor Bhanumati that we are not able to inculcate the fact that we have so many postgraduates. Most of them don't seem to be interested, and in fact, in my hospital also, I keep telling them to write a case report or just report a interesting case. Seems to be lost. The interest is not there unless they develop it among themselves. I think it is such a wonderful experience and wonderful chance for them to publish something in a journal. It's so important now because now we don't have a dissertation. I think it's important to publish a thesis, a paper, and all that. They could probably take this opportunity, all postgraduates, and probably cash upon this. And this journal is going places, sir, I'm very sure. Many congratulations and best wishes.
Thank you, sir. Professor Rajnikant or Sarojini. Ilango.
Not done much publication, so I don't think so I'm fit enough to qualify to talk here. But what I requested is whether we can write technical parts in surgery. This is a purely gastroenterological part, and most of the work I'm involved in is a technical part of the gastroenterological problem, which I feel if there is an opportunity, that will be a mode of expression for all of us, surgically. How I do it in small things. That will be helpful. Thank you.
Murugan, sir.
My first thought as a promise that definitely I will get more involved in the academics. I have been lazy, but we were just talking about it, so definitely we'll get more involved. Secondly, I was just wondering if there is a lack of statistic support or any other logistic support, which is one reason why some people are not able to do. So can we provide that support through this organization? I don't know if it is possible. Mainly statistics is a problem in many centers. Even in Apollo, we don't get good statistical support. So that may be one reason why people are not coming forward. And even some people, like students, want to write, but they don't know how to go about it. So is there any additional support we can give as a group, which may increase the publication? Just a thought.
I think that was discussed even, I think, last meeting. And, we thought of putting some statistician. Maybe we look into that. Saravanan? Saravanan, who's interested in a lot of publishing, please come on.
Yeah, thank you for calling. Yeah, so I think we can have single themed editions where we can put together some thoughts, review articles, so that it will also attract students, because for them it will be like everything combined together. So for exam perspective also it will help them. And yeah, I think the way forward is also to give some sort of support in terms of statistics. We can have one edition dedicated to statistics, so they could use that as a reference point in future for statistics or whatever. So that way, if we can give some support, it would be, I think, helpful. That is something unique which I think other journals will not have looked at. And also how I do it. So those kind of things I think also will be helpful. Yeah. Is already there, yeah. So maybe we can look at any other additional sections we can add. Yeah, and we can ask the postgraduates to give those topics what they want, like that. Yeah, thank you.
Thank you. Anyone else? I think that comes to the end of our editorial board meeting. My sincere thanks to the man who is not here, but is the backbone of both TNIG Trust as well as the journal, is Dr. Professor Balasubramaniam. We misuse are here, but he's watching in the Zoom, and he's the one man who never says no to whatever we ask. And thanks to his effort and belief in us and support, we sincerely thank you. And we move on to Secretary's report. It will take only a few minutes. So our TNIG CRS history was completed, and Dr. Ebi is on the process of writing the manuscript, and soon I think we will publish it. And the upcoming project will be the Plex study, which is the initial pro forma was given by Dr. Alamai, who is the lead coordinator. Subsequently, we had a core committee Zoom meeting in the first week of November. There are some suggestions, and probably we thought that this will be split into two studies, and one is going to be a Plex on acute liver failure. The second thing is all Plex patients we thought of putting together and having some analysis, because Plex is doing in a lot of patients without any specific exact criteria and indications, and we thought we put plan some guidelines. Again, Professor Epen is behind all the ideas, and hopefully Dr. Alami is working on this week, and maybe we'll have one more meeting of the core committee, and we're supposed to start before this year end. And alcoholic liver disease, again, it is Professor LVK is working on it. Initial performer was ready, and we have to make it the performer more perfect. And after that, we'll have a core committee meeting, and we'll put on it for probably the next year. So the next meeting will be our year-end celebration on 29th December. ISGCon Jaipur will be in our national meeting in January 5 to 8. And we have our annual meeting was fixed at Trichy on 25th, 26th of March, which will be organized by Dr. Ravi and his team. It is in Hotel Marriott Trichy. This is the first star hotel in Trichy. And coming to today's CME, I think the initial idea was given by Professor Ramakrishna, and we have 3 topics, and I request the chairpersons, Dr. Murugan, Dr. Sheshadri, Dr. Nagnath Babu, and Professor Rajinikanth to come over the dais and carry over the further proceedings.
Good evening. We'll get on with the scientific session. See, small bowel is an organ which is very reticent to disclose its secrets. In our initial days, it was a big struggle to get to a diagnosis of small bowel disease. Of course, all of us remember the GE radiology meetings conducted in our MMC, where stalwarts, Professor NMG, Professor NR, Professor Gajaraj, and our own Dr. Raghuram were there. They used to put up Berry Mill series and ask one of us to see, and they'll have a good fun when we're struggling through this, creating these pictures. Of course, first initially we had a plain X-ray. Of course, Professor NMG would never see a case without a plain X-ray of the abdomen. Then we had Berry Mill, single contrast, double contrast, and later on other modalities of investigations have come. And so now we have so many ways of diagnosing small bowel disease, including these capsules and enteroscopy and all that. But today's subject is mainly imaging the small bowel. I have great pleasure in introducing Dr. Karthikeyan, D. Karthikeyan, a senior consultant and head of the imaging sciences in SIMS, Chennai. He has had the honor of delivering several orations, including Dr. Ida B. Scudder oration for year 2018, and also Indian Radiology Association's orations. He is an author of many handbooks, and he has special interest in neuro, body, and oncology cross-sectional imaging. And we are very eager to listen to you, sir, about imaging small bowel. Dr. Karthikeyan, please.
Good evening. Thank you for giving me this opportunity. When Professor Ramakrishnan suggested this topic, I just realized Dr. Ubal's tagline. A couple of years ago, he had organized a small bowel seminar, and I think the tagline was, I don't know whether he remembers, lighting the dark tunnel, and which is very apt, I think, for both clinically and in imaging. We have come a long way in assessing small bowel. I'm sure you all agree that symptoms are vague, and most of the times, by the time I think they come to a specialist gastroenterologist, multiple imaging would have been done, and typically 3 to 6 months or a year would have gone before they land up in a place where we decide to do the appropriate correct imaging. And what I'm going to do today is just a compilation of our own experience, and my own personal interest in small bowel imaging started because of my association with Professor Ramakrishnan, and we were very fortunate through him to be part of the team which formed the guidelines for small bowel imaging a couple of years ago, and it's one of the good collaborative guideline which I think all of you should read, because every possible question is answered in an Indian scenario. It's not like we just copy pasted everything. If you are in a tier 2 city, tier 3 city, what to do. If a child comes, you cannot give a sedation, what to do. So it covers all the nitty-gritty so that good imaging is done and appropriate diagnosis is made. Now, most of the imaging will be like this. Patients come either with abdominal pain in the acute presentation. It will be a collage of cases. So this is one of the enteroclysis. We are not as apt as you people to place the tube inside. And finally, I think we were very happy when it was replaced with enterography. And the day we discovered that mannitol 100 ml bottle, which is very cheap, which solves all your issues with imaging the small bowel, we are very happy. And that's one reason why small bowel imaging happens everywhere now. So this is typically what happens: acute abdominal pain, diarrhea, fever, or this is how most of the patients will present. So the differential diagnosis for something which is like this, which is acute, where there is fluid, edema of the bowel, the folds are thickened, will start with hemorrhage and go till the Crohn's disease. So what is vital is two things. One is clinical history, and second thing is additional non-bowel imaging findings if we can pick up anything. So typically from an ER, before any of you see, imaging is done. Even before the blood is drawn, I'm sure it is the same in most places. The patient lands up, and before the blood is drawn, a CT is asked, and so most of the times we don't get much history. Because in the night, it's managed by the ER, and by the time the next day morning, they come to you and we discuss it, it's too late. So we try to find additional information, either in the spine to look at whether there is some form of spondyloarthropathy or something in the lung. Whichever additional area what we have screened, we always go into it. And like that, we realized this patient had a surgical valve replacement in it. So this helped us to kind of narrow the differential diagnosis to, we asked them to look at the anticoagulation parameters, whether the coagulopathy was there. So this is a case of hemorrhage inside the small bowel. Now the other thing, again, I look at it, similar complaint, sudden onset of pain, vomiting. Patient comes again, most of these patients somehow come late in the night. And what we see is circumferential wall thickening, mostly in the proximal bowel, mesenteric edema and ascites. So the danger of something like this coming in the night is whether we shouldn't misdiagnose an infarct, ischemia, when there is an inflammatory bowel disease. So this is a real world situation. So one thing what we normally don't get is this. When we do this scan, we don't get this. So we always prefer discussing with the people involved. So in this patient's serum lactate was normal, very marginally elevated or normal WBC count. So this happened in the night. So my residents thought it was an inflammatory bowel disease, jejunitis. But later, most of the times it so happens, he comes for the morning rounds and we sit and discuss, and clinically, sir will tell, okay, this is there, this is not there. And finally, we realized it is a angioedema, which is probably related to some drug which is happening. So this is how small bowel imaging has to be practiced. It is an MDT before you come to a diagnosis. Now, there are a lot of changes in techniques. Most of the times, if we remember, CT scans used to be done with positive oral contrast. You will find a lot of positive, bright bowel, which we realized over the years that it is a enemy for the mucosa. We realized with multi-detector CT, we are good in picking up the mucosa. We are even good in picking up the ulcerations. I'll show you a few examples. So this is typically what will walk into most of your hospitals. 6 months of going around, anemia, has been diagnosed to have melena, sometimes fresh blood, 3 CTs, multiple CTs. And when we reviewed it, we realized it is not that the images were bad. It is just that they had used positive contrast. So what positive contrast does effectively is it kills the mucosal enhancement. So in fact, in this patient, finally what we realized is what is given in almost all textbooks. It was a small Meckel's diverticulum which was enhancing right there. So this is a typical example of why technique is important. Even though now multi-detector 128 slice CT is available even in villages. So essentially, each center will have their own practice. So the onus will be on the referring clinician. Like if you suspect a small bowel problem, you please insist on a negative contrast. Mannitol is available everywhere, so it can be done anywhere. Now, prior to enterography and multi-slice, small bowel imaging has always been a challenge because most of the times the only diagnosis we will be able to give you probably 10 years ago was thickened bowel loop seen, and if we are smarter, we will localize it to either the DJ flexure, proximal jejunum, or ileum. And what we have understood is physiology of small bowel dictates to a large extent how your study comes out. So it can be, we used to do it with water, but as all of you know, water runs off and it gets absorbed, and by the time you give him a liter of water, you put him for a plain scan and inject the contrast, the water would have run away. So the appropriate modification, what we realized is, you make the patient drink Peglac, then coloprep, and then prepare him for a enterography. It is just not possible. So nowadays what we are using is, we are using coloprep itself as a luminal distending agent. So many of them come from outside. They cannot stay for a day to prepare the bowel and then come. So we preferably schedule it in the mornings. We give them coloprep. Coloprep adequately cleanses, and at the same time the residual fluid which is there gives you a good differential contrast for looking at the mucosa. So that is one modification which can be practiced. Anatomical facts I wouldn't go through in detail, except that most of us have become adept at looking at the mucosa, the valves, the valvulae, the serosa, both in the ileum and in the jejunum DJ flexure. And these are the guidelines I've seen. It is available for free download. And those of you who are interested in the imaging part of it, you can go through this. Now, these are the options available. So based on what the indication is and how the availability is, we can do a CT enterography, or a typical triphasic study. If additionally you have a pancreatic lesion or a liver lesion, we switch on to a triphasic mode. And with the advent of the newer generation CT, almost all CTs are triphasic or quadriphasic. Quadriphasic meaning we take an early arterial phase to pick up early angiodysplasias as far as the small bowel is concerned. And for people who have polyposis or who have genetic predisposition, who need to undergo multiple bowel imagings, we have low dose CT enterographies. The dose is so low, it is like getting to abdominal or a chest x-rays. So even though enterography is good for mucosal studies, sometimes because of the lot of artifacts and the time factor, a typical good enterography will take around 35 to 40 minutes in a good trained center. But a CT will hardly take 5 to 6 minutes in any center. So based on the availability and the need, even if you want to do a CT enterography 2 or 3 times a year, all we need to do is to request them to do a low dose protocol. And the plain scan, these are the normal scans what we used to do. These are the oral contrast, and these are the enterography pictures. We used to do enteroclysis. Enteroclysis still has a role when you are suspecting a very small stricture. One of the pitfalls of enterography is it distends the lumen, but not to the extent an enteroclysis will do. And these are MR enterography pictures. The advantage of MR enterography is based on the sequence what you use, you get a biphasic contrast. In some sequence like T2, fluid is black. In some sequences like T1, where we use post-contrast T1, the fluid is dark. So you get a biphasic contrast study, and it is good for picking up small polyps and mucosal details. So enterography is a good tool, and these are the normal enterography findings. We look at the jejunal mucosal pattern, and this is something which I think all of you inherently remember, but just to emphasize, the first thing which should strike us is the jejunal folds and the absence of folds in the ileum, because that that is something very often we see when patient comes with non-specific complaints of malabsorption. Now, coming to the common indications, the accepted indication which all of us use is inflammatory bowel disease, especially Crohn's disease. The development of CT and MR enterography is closely related to the development of Crohn's disease and its management. Small bowel tumors, abdominal pain and diarrhea of unknown origin. This is something very interesting because it's challenging, and it's always an interesting dialogue what we have when a patient comes with it. And obscure gastrointestinal bleeding. Again, the challenge for an obscure gastrointestinal bleeding is to pick up the bleeding points so that we can give a roadmap prior to any embolization if it is needed. So the goal of small bowel imaging of whatever modality we use is to distend the lumen and visualize the walls, assess the vascularity and the adjacent mesentery. These are the MR pictures. I wouldn't go much into the detail, except that unlike CT, MR gives us the ability to image with multiple contrasts, and there is something called diffusion imaging, which picks up very early inflammation. When the mucosal inflammation begins, diffusion becomes positive. So that is one of the greatest strengths of MRI. And this is the protocol what we use, 1300 to 1500 and 200 ml of 20% mannitol. This will give you a fantastic enterography. The difference between enteroclysis and enterography, which I've already told you, the distension is much better in enteroclysis, but then not all patients need an enteroclysis. We can use mannitol, you can use PEG-LEC or Coloprep, whatever is available with you. And the advantage is this. Typically, this would have passed off as a thickened area of terminal ileum, but what we will expect now is thickened enhancing terminal ileum. So this is an hyperacute Crohn's, which would have been missed if we had used a positive contrast. So the advantage of a negative contrast. CTE, MRE, the advantages of CTE is very accessible, available everywhere, very fast, few seconds it can be done with, can demonstrate active disease distribution. Disadvantage of radiation, it is just a template which we put in all the slides, but with today's CTs, radiation is something which we can neglect, we can ignore. MRE, extremely useful in mixed disease, especially in Crohn's, where you want to know whether there is an element of fibrosis along with active inflammation. So those are the areas, and especially when there is a follow-up. But whenever a patient comes, even a pediatric patient comes, always the first imaging is preferably done with CT, because the artifactual problems and misdiagnosis with CT is much less. So what happens typically is, if the first imaging is MR and it has been done very suboptimally, to convince the patient to undergo a CT will be a real problem, and this is one of the real clinical scenarios where the lesions get missed. So serial radiological, when you want to problem solve in a Crohn's follow-up, you can always use an MRI. So this is the first step. Most of, when we train our radiology colleagues, the first thing what we ask them is to understand normal anatomy so that they understand what is abnormal anatomy, which is pathology. So if you can see here, you find small hypodense nodes. Even though jejunal folds are there, you find more fluid in the jejunum, and you find the ileal folds also to be prominent. So this is a classical case, and again you can see the MR enterography picture. It is self-explanatory. You know there is jejunization of ileum. So again a CT picture of the same. So reversal of jejunal folds, low density mesenteric nodes and mural thickening. So this is celiac disease, very often missed because this is not observed. Why this is not observed is people assume whatever looks like jejunum is jejunum. But these are loops at the anatomical location of ileum. So jejunization of ileum is something which should not be missed. And the second thing, what very often patients come, of course, when they come, there is not much of a history, but on direct questioning, a lot of times patients with connective tissue disease do present to you with serositis, pancreatitis, abdominal pain, distension, and this is a classical appearance of how a vasculitis will look. Hyper-enhancing loops, and I can see Professor Raghuram here. I was a student of Professor IK, and innumerable number of times I've actually stood presenting and got ragged. Those days barium was there and it was called as stack of coin sign or picket fencing sign. So this is the CT equivalent of the same classical case. Again, history is of paramount importance. The other thing which is very challenging for us is to pick up obscure gastrointestinal bleed. So one takeaway point which you should insist all your radiology colleagues when you ask for the exam is, I always do a plain scan. Why this is important is many private centers and few hospitals, when you send them for a CT, in order to save the time, what they give is they give the positive contrast, make the patient wait, because the idea being it takes 30-40 minutes for the ileum to opacify. So when they do like that and you end up doing a contrast, the bleeding point is lost. So any obscure GI bleed, be it melena or fresh bleed, you always get a plain scan done. Two things it will serve. One is you find the sentinel clot, which may give you a clue to where the bleeding is happening. And second thing is it helps you to understand the enhancement pattern. So in this patient, again, you can see a small speck there. And arterial phase and venous phase, slowly we find the pooling of contrast increasing. Here we didn't find any nidus, so this is what mostly we find in geriatric patients who are on anticoagulants, and they come with melena, small erosions or small areas of focal bleed. The other thing is straightforward case where there has been a torrential bleed and the plain scan shows you a tumor, and what you want to see is the nature of the tumor. So this is a case of a exoendric intensely arterial phase enhancing tumor. So it's a carcinoid. Then subsequently we started looking at the arterial phase, the enteric phase and venous phase, and then we have started following this endoscopic classification. So the CT equivalent of this endoscopic classification is, I'll show you a couple of examples. The angioectasia, which is seen only in the arterial phase, in the enteric phase. A diploid lesion, which is seen in the arterial phase. So if you see the endoscopic or enterographic correlation, the equivalent in CT imaging will be like this. So this is why it is arterial phase. You find that it is intensely enhancing, almost same as the aorta, and it is de-enhancing in the venous phase. So it's a diploid lesion. So we are able to even characterize. So initially picking up a lesion used to be a challenge. Then we became good in picking up the lesions, but now we are becoming better in defining what the lesion is. So here again you see a lesion which is enhancing in the venous phase, but it is not seen in the arterial phase. So this is an angioectasia. So this is the temporal contrast characteristics of an arterial lesion. Any hypervascular lesion will be enhancing much in the arterial phase, but when it goes to the enteric or the delayed phase, it will de-enhance. So these lesions are AV fistulas, aneurysms, tumors. Cavernous angiomas, low-flow AV malformations will behave like the venous lesions. Slowly over a period of time, they increase with contrast. So that's how we characterize bleeding disorders. And this is something which has kind of become a fad with us in the last couple of years. Especially, we have converted most of our CT into an enterography, because instead of water, we substitute it with mannitol. So all our studies, except for those areas where we think oral contrast is needed, especially in picking up strictures or a stenosis or a tumor, we don't use positive oral contrast. And this is something which we have quite often picked up at least 2-3 times in a week. Probably it's because of the referral predominantly from gastroenterology. You find thickening of the jejunal loops or the duodenum, and most of these patients present to us with a typical history of pain abdomen. And eosinophilic gastrointestinal disorders is something which we think we have become better. Sir has to vouch for that. And see here, it's isolated patients with defined abdominal pain. And based on the degree of involvement, I think there is a classification, I think it's called Keynes, or some, based on whether it is mucosa which is involved, muscularis which is involved, or serosa which is involved, the spectrum of eosinophilic disease presentation will vary. But most of the times, what we see is the mucosal disease like this, where you find edematous thickened folds. There is no periserosal changes. So this is something which we see in routine day-to-day practice. And now coming to the crux of my talk, which will be inflammatory bowel disease. When I was preparing for this talk, I realized IBD stands for IBD. This is the mnemonic. You look at the inflamed mesentery, contents of the mesentery, lymphadenopathy, fat changes, engorged vessels, bowel change, thickening, stratification, a permanent structural change, and disease complications, strictures, dilatation, cancers, fistula, abscess, or perforation. So this is how, and Crohn's disease is something which is the basis of most of the IBD work. It's classified into 1, 2, 3, 4, 5, 6 active inflammatory subtypes. It's quite easy and straightforward to diagnose. Fibrostenotic subtype, and to declare something as quiescent, and regenerative types or something which will need always an MRI enterography. And from the second stage, transmural inflammation, most of the cascade of pathogenesis can be imaged with CT or MRI. And this is the template what we look for. We look for bowel wall thickening, contrast uptake, mural stratification, mesenteric vascular engorgement, and MRI specific signs or increased signal intensity in T2 image, and whether it is bright in diffusion. So these two help us to characterize the activity in a complex case. Acute stage, self-explanatory, thickened, enhancing mucosa, periserosal stranding. Acute inflammatory, you can find the T2 enhancement there. And this is something which has to be used, we use very often. This is a normal patient, and this is a patient with Crohn's disease. If you see carefully, you can see compared to this is hypomotility is there. You can see there. So hypoperistalsis itself is a marker of inflammatory bowel disease in the absence of any other. For some reason, you are not able to do a contrast. You want a limited scan. You can use this also. These are all in the initial stage MR, not for the follow-up patients. Again, I've highlighted the laminar pattern of enhancement with the comb sign. Ulceration and nodularity, both in CT and MR, can be picked up quite adequately. Mild active inflammation, the symptoms are there, but the equivalent of CT in early imaging will be something so specific like that. If you can see there, at the terminal ileum, there is mild enhancement. If the clinical picture is appropriate, you can get a diffusion imaging done. You can see the diffusion equivalent of the same patient, where isolated terminal ileal inflammation is present. Stricture, one of the commonest thing will be, is it inflammatory or a fixed stricture? So this is a comparison in CT. You find mucosal enhancement, transmural thickening is there in compared to the fibrosis where there is narrowing. Again, with fibrosis, you can do a dynamic MRI. Again, inflammatory versus fibrosis. Lot of times in fibrosis, you find the submucosal layer replaced by fat. So that gives you an indication that this is a chronic. Short fibrotic strictures. there. You can see patient was symptomatic. All the other areas were normal. It was a discrete area of stenosis, and this is where luminal distension and MR comes into play. And this is what I was telling. Fibrostenotic, where you can do a dynamic to see that area is fixed stenosis. One of the problems with the fixed fibrostenotic lesion, where the thickening, my cutoff is around 14 or 15 millimeter wall thickness. Whenever is there, we always suspect malignancy. Fibrostenotic reparative phase, where you find a lot of granulations or small polyps there, pseudopolyps. Fistulas are quite common. Interloop fistulas can be in all shapes and sizes. The stellate fistula is what we commonly see in clinical practice. Ileal stenosis with a ilioileal fistula. Again, a stellate stenosis. These are some of the times where we need to give positive oral contrast to see for interloop fistulation so that it is easier for us to tack. Intravesical fistula. Post-op disease surveillance is something which is becoming very common because with improved treatment, I'm sure all of you know, many of these patients continue to come for follow-up, and post-op surveillance, CT or MR, both have been found to be good. Neoterminal ileum with acute disease, MRI of the same. Subcutaneous fistulous tract, iliotransverse anastomosis with fistulization, sometimes sinus tract with local tethering of the bowel to the bladder. So these are areas where sometimes mixed phase, where you find areas of enhancement and hypoperistalsis together. You see that area of ileum is not enhancing. Again, discrete, it's a 3D from the MR enterography picture, discrete lesion. It's almost like an apple core. Inactive disease, you look for saculations, you look for narrowing, loss of enhancement. Perianal Crohn's is a topic by itself. So most of our protocols in MR will always include the pelvis. So even if the patient is not symptomatic for perianal disease, whenever you are planning for an enterography, the index enterography should always contain perianal area. They keep coming to you with abscess in all areas. We have seen patients with osteomyelitis of sacrum, perirectal abscess. Monitoring treatment, extremely good MR, normalization of parameters, lab parameters, and also you look for normalization of enhancement and diffusion in MRI. Active disease, same patient with inactive stage. Now, when to suspect malignancy, I've already spoken to you. My criteria is lack of enhancement, lack of mural stratification, and a wall thickness of more than 15 mm. As you can see here, long-standing dilatation of the proximal bowel, fixed stenosis there. And this was one of our first patients 8-9 years ago. In fact, this case started my journey with imaging of small bowel disease. This turned out to be an adenocarcinoma. She refused any surgery electively, and she came back to us with perforation. A quick look at other causes. All-time favorite of surgeons, acute appendicitis. A lot of times a matted perforated appendix may mimic a terminal ileitis. Small bowel obstruction, extremely good. In small bowel obstruction, we use the native pooled water itself as a contrast agent. And this is something similar to barium, where you find the beak sign. We look for the zone of transition. This case was a band. SMV thrombosis there. You look for pneumatosis and also thickening. The difference between an arterial and venous thrombosis, most of the times venous thrombus mimics an acute inflammatory bowel or a vasculitis because there is hemorrhage within the mural wall. Sometimes you find unexpected diagnosis like an entrix cyst for a patient who was suffering from on and off obstructions and malabsorption like syndromes. And this is something which we have come across once in a while. Case of malabsorption, long-standing, multiple imaging done, And you can see a fixed loop of dilated ileum with no proximal or distal stenosis. It was a fixed loop. This is a focal ileal aneurysmal dilatation of ectasia, something similar to a Hirschsprung's. This is the volume rendering of the same. So sometimes this case you have already seen, you know what to expect. There are not much of surprises. And this is the enterography template. I think the message is it's both ways. Unless you demand, your radiology department is not going to give you all this. And this is a comprehensive template which answers everything what you need in managing an inflammatory bowel disease. Few exotic once in a while findings, a case of sciatic hernia. And again, I'm reminded of Professor Raghuram IK's days, a case of abdominal cocoon. Professor IK was my mentor, and cocoon was one of his favorite topics. You find a cocoon with a band there. And again, a very common favorite topic for all of us, Peutz-Jeghers with a large lesion with intersusception. So this in a nutshell is brief pictorial review of small bowel. The only take home is, I think all of you should adapt to a negative contrast, which is either water, mannitol, or sometimes we have used even soya milk for limited imaging. And I think it is a discussion. Most of the times, a non-IBD diagnosis happens only with discussion. IBD is same anyway. Picking up a bowel wall thickening is the easiest thing. Characterizing is tough, and that is where an MDT comes. Thank you once again.
Thank you very much, sir, for taking us or lighting up the dark channel with exciting pictures. Of course, there will be some questions, I think. But before that, sir, my own doubts. We often read the report of paniculitis.
Yes,
so
sir.
what is the significance of this paniculitis?
So it's a
second question is whether
yes.
you can diagnose Meckel's diverticulum by radiology.
Yes. Paniculitis is a non-specific inflammation of the mesentery. Most of the times it's an incidental finding, especially in diabetics. So you image them for something else, you do find paniculitis. But sometimes a very non-specific, mild, non-specific inflammation, you do find extensive paniculitis. The only thing is, it looks very scary. Once you are very definite that it is only paniculitis, it is not a periserosal inflammation secondary to a primary bowel disease or a small appendigitis. Most of the times, focal pain and what looks like a paniculitis, if you look carefully, will be an epiploic appendigitis. But if it is in the central mesentery and if you are pretty sure no primary bowel pathology is there, many of them, I think, respond to anti-inflammatory drugs. And coming to Meckel's diverticulum, good imaging, that's what I said, with a good preparation, when a patient presents with pain or with bleeding, 80 to 90% of the times it's always a missed diagnosis in imaging. When you look back after a technetium scan, you always see that lesion is there. With appropriate bowel preparation and a good arterial and venous phase contrast, you should be able to pick it up. The advantage or the disadvantage of the present generation CT is the images are always there. So retrospectively, when you look up, most of the times we realize it is a miss by us. It is not that the modality has not picked it up.
Two questions. One is, one common scenario we face is patient coming with a small bowel type of pain. We get a CT done, and report is mild terminal ileitis. Little enhancement of the terminal ileum. Quite often we do a ileoscopy, we find it's a normal mucosa. Biopsy is non-specific again. Again, we are lost. So, is there anything, additional points in the CT which can
Yeah, two things, sir. One is radiology bias and referral bias. I'll tell you why it happens. Lot of times when you refer a patient who is having chronic symptoms, And when the radiologist tries to look for a finding, the commonest finding you find in a CT is two things. One, jejunal mucosa, when it is suboptimally distended, will look thickened. So these two findings, you will find it very often: thickened jejunum or thickened small bowel, and terminal ileum. Inherently, terminal ileum enhances. And you look for ancillary signs, whether there are reactive lymph nodes there. And in this scenario, one of the commonest diagnoses, what we ask first, if appropriate clinical scenario is there, is enteric fever. Many times, if you go back through the history, they would have had some episode of fever, diarrhea treated. That is one. The second thing is, it is purely based on the clinical scenario, whether you should give importance to this focal area of enhancement. If on a subsequent visit, say after a week or 2 weeks, if you still find the patient is having symptoms, then an MR enterography, at least a limited MR enterography where you do a diffusion imaging. And if the diffusion imaging shows a terminal ileal, bright area, then you are pretty sure you are dealing with an enteritis. So it all depends on how much significance you give to the clinical scenario and if the patient comes back. And being in a hospital practice, it is easy for us to actually, when a patient comes back with a recurrent complaint, many times we do a academic screening, which may not be possible if you have a standalone kind of practice. So that is one of the reasons why a lot of patients get missed. Yes, sir. It is useful, especially in pediatric patients. It is not useful as a primary diagnosis, but for follow-up. High-resolution ultrasound is very useful, and in between the episodes, you can always, if there is no clinical dilemma, ultrasound you can use. We sometimes use it in adults too, and we reserve the follow-up imaging only if we suspect a complication or some clinical symptom which is not explained, either an acute symptom or he's not responding to therapy, your lab parameters are not consistent to what you will expect. But ultrasound role is well defined, especially in a pediatric patients we do use.
So, I think one last question from Dr. Ganesh.
Negative question, sir. In the era of small bowel videoscopy and enteroscopy, how much does MR enterography stand in the future?
So there will be the answer to your question is again the technique. So consistently, you will not be able to give the same technique. Even in our center where we are so experienced in doing it, I cannot guarantee the same quality. So most of the time, say in our centers, if you take maybe 30 cases, maybe 2-3 cases may go for a capsule endoscopy. Sir, your comments? That's where I said, retrospectively post capsule endoscopy, if you see, the only thing what we have retrospectively not been able to pick up post capsule endoscopy is small areas of erosion, or when you are looking for a chronic bleed, anemia assessment. If it is going to be a structural lesion, a second look MRI, many times we will be able to pick up. But in our center, when we retrospectively go and see what we have missed, it has always been a small erosion or a small focus of bleeding, which is on and off. The pitfall of CT is active bleeding. You need at least 0.5 to 0.6 ml of active extravasation to happen. So a chronic anemia, where you are searching for a erosive kind of bleed, CT may not be of helpful. In that setting, you use CT as a negative marker to go upscale it to either an enteroscopy or a capsule endoscopy.
Thank you, Dr. Karthikeyan.
Thank you.
It was a wonderful speech, and a good overview of the small bowel imaging. I think it's a very huge topic. It's so a very good overview has been given, and we'll proceed to the next topic. Thank you very much.
So next we will move on to the gut microbiome in GA diseases. How relevant is it to the physician? It's going to be delivered by Dr. Rupjyoti Talukdar, and he's the director of pancreatology, Asian Institute of Gastroenterology. And his major research areas include molecular mechanisms of clinical acute pancreatitis and complications, pain mechanisms in chronic pancreatitis, pancreatic stellate cells inflammation and beta cell dysfunction, gut microbiome in pancreatic diseases, genetics of recurrent and acute pancreatitis, and is a fellow of Indian College of Physicians and also American Gastroenterology Association. He has more than 100 full-length scientific publications, and he has contributed to more than 35 chapters in various books, and he has delivered more than 150 invited lectures in international, national, and regional conferences. Over to Dr. Rupjyoti Talukdar.
Yeah, a very good afternoon. And at the outset, let me thank from the core of my heart to Ramakrishna sir, Dr. Ubaldos, and the TNISG for this kind invitation. So what I'm supposed to do is to speak something on the gut microbiome and GI disease. And is it really important for the physicians to know about the microbiome? I mean, we all treat patients with probiotics, antibiotics, maybe fecal microbial transplantation, but is it important to know about the little bit of the core of the microbiome? So when we talk about microbiome, usually what comes to our mind is bacteria. Most of us think microbiome means largely bacteria, but it's exactly like this tropical rainforest. If you see here, just the tropical rainforest has so much of species of different birds, animals, flowers, plants. Even the gut microbiome is actually composite of viruses, bacteria, fungi, archaea, protozoans, and helminths. In fact, the most abundant organisms in the gut are the viruses, not bacteria. And then stands bacteria followed by the others. So before going into the diseases proper, let me take you back through evolution a little bit. So if you see here, this is where the universe began. I'm not sure if it this doesn't have, So yeah, the universe began somewhere where, and the bacteria were actually the first earliest organisms. But initially, what was the environment like? It was anaerobic. So there was no oxygen, no life forms using oxygen. But something happened around around a few billion years ago where an organism called cyanobacter developed, and it started developing photosynthesis. And that is why we are what we are now. If that mutation would not have happened, cyanobacter would not have evolved, probably we would have been here today because it would have been all anaerobic. And we still have those microbial signature of cyanobacterium in all these seas. And this is the Australian highland where these are the microbial mats, where these are all evidence of those early organisms. Now, has these organisms changed from the beginning of the life to now? So this was a very elegant study that evaluated the ancient microbiome, that was picked up from this. Actually, this is in the Swiss Alps. Some explorer, when they went up to the Alps, they found a mummy. So they thought some mountaineers must have fell from the cliff and died and mummified. But when carbon fingerprinting was done, it appeared to be a corpse from 4,000 years back. So they could fortunately take out stool samples from the intestines. And then again, stool samples from this soldier from Second World War 93 years back were also a sample. And these are called coprolites, which are mummified fossils of stools, fossilized stools. So when they looked at the microbial composition and compared with the normal current human microbiome. So if you see, this is so interesting. Again, this doesn't seem to work. Yeah. So these are all the microbiota of the ancient humans, and this is the microbiota of the modern human. And there is significant similarity of the ancient to the modern human, which means that it has largely been conserved. And this similarity was seen mostly in the humans who comes from a rural background, who have been in the rural areas. So this means that the current rural microbiome has significant similarity to the ancient microbiome, which is again an indirect marker that more we are closer to nature, more we are living an organic lifestyle, we would have a more healthier and earlier microbiome. So the microbiome actually in the human body is shaped by several factors. The first is the mode of delivery. Then the first feeding, is it breastfeed or formula feed? Formula feed is becoming very popular these days because of the working mother and lifestyle. And then from actually around 3 years of life, 70% of the microbiome in the child mimics the adult microbiome. And then it goes on all throughout old age with several modulators such as the diet pattern, the type of diet, preservatives, and the geography, the biodiversity, the use of antibiotics, host genetic interactions, and of course alcohol. And again, another interesting thing, even we talk about, as GI guys, gut microbiome, gynecologists would say about the vaginal microbiome, or a dermatologist would say the skin microbiome, but these are not discrete things. These are all interrelated. Microbiome of all sides of the body talk to each other. And this is again just like a change in somewhere else in the world would lead to the Arctic ice melting. So if we have a problem in the GI tract, the microbiome of the urogenital tract may be affected or the vice versa. So whenever we talk about treating microbiome, it should be from a holistic approach. So what does this microbiome do in the human body? There are several functions which can loosely be divided into metabolic, defensive, or trophic. Metabolic, the most important function is the carbohydrate fermentation, which leads to synthesis of something called short-chain fatty acids, and these are what maintains the gut. The most importantly, the butyrate. So that is maintains the gut health, that provides food to the colocytes, and that's how the gut barrier is maintained. The other important among many is bile acid metabolism. It depends on how much organism or what is the diversity organism is there in the colon or ileum, and that leads to bile acid metabolism, and that can have lots of connotation in development of carcinoma, colon. And then drug metabolism. Defensive, very important, is induction of antimicrobial protein synthesis, which protect us from pathogens, yet allow the common cells to live. So this is a very beautiful symbiotic relationship where both the microbiome and the host immune system develops concurrently in such a way that the pathogens cannot penetrate the gut wall and invade the intestines, and at the same time the common cells are not killed by the organism. A low level of physiological inflammation goes on at all points. And then finally, I already talked about the maintenance of gut barrier integrity. So this is how the desmosomes and tight junction proteins are modulated, and that maintains the gut barrier. Now again, in every GI meeting, every talk, this problem comes. Which came first? Like everyone talks about this is associated with the microbiome, or microbial dysbiosis can cause this disease. But again, is it the microbiome first or the disease first? And what now it appears as it's not a single way traffic. A healthy microbiome can never cause a disease. It's always friendly to the person. So if a microbiome is changed because of some disease process, the dysbiotic organism can in turn contribute more to that disease or another disease. And I'll show you some example on that. So now let's quickly move on to today's primary talk. The gut microbiome in GI disease, and pancreas is in the core of my heart, so I'll be a little biased on the microbial changes in pancreatitis because we have some work on that. So again, let's start with this common clinical problem, acute pancreatitis, walled-off necrosis. And for referral centers, this is a big problem because this patient will come with infected necrosis, and there is a common practice, not only in India, all over the world, to start prophylactic antibiotic. Unfortunately, even it is recommended against, but these people start getting prophylactic very early on, and then we do not know when to stop. So these patients keeps on getting, yet they develop infected necrosis and fare very poorly in this in the clinical outcomes. So why does it happen in spite of getting so much of higher generation antibiotic? So this is where we started thinking, is there anything going on within the world of necrosis? And what we did was, we looked at the fungome. So that's why I was saying microbiome is not only bacteria. So we looked at the ITS portion, fragment of the gene by doing gene sequencing. We took out the fluid from the world of necrosis during drainage. And then when we looked at the profile, an organism with the genus called Aspergillus came up in a very high proportion in the world of necrosis fluid. So we thought where it has come from. Then we looked at the stool fungome or the intestinal fungome, and the similar picture appeared there also. The organism Aspergillus penicilloides was in a very high abundance in the intestine. So to bring up a link between the intestinal dysbiosis of the fungus and the fungus in the intestine, in the world of necrosis, there has to be some barrier abnormality. And this is what we proved by looking at the fatty acid binding protein in the intestine, which showed that there was gut mucosal barrier loss or abnormality. And then when we looked at all the three areas, the stool, blood, and WON, the similar kind of fungal profile was seen with Aspergillus penicilloides being the highest. So this shows that in these patients, initially probably because of the antibiotics or probably because of the disease pathophysiology, the fecal or the intestinal fungome changes has happened that led to barrier loss, translocation into the blood, and finally colonization into the world of necrosis. So probably this may lead to some kind of randomized control trials. Difficult to say, will early antifungal help in a subgroup of this patient? Of course, it won't help all patients. So that can be food for thought. Can it be a RCT, the next step to in these patients? Now, if we look at the other literature on acute pancreatitis and the gut microbiome, there are several studies which have shown alteration in the gut barrier function, alteration in the bacterial species, but my problem with acute pancreatitis and gut microbiome studies is again because of the antibiotic use. We do not really know, is this alteration because of antibiotics or because of the disease itself? What proportion is contributed by what? So I'll just take this data with a pinch of salt. Let's quickly go to chronic pancreatitis. There were earlier studies that showed there is a small intestinal bacterial overgrowth, various individual studies and meta-analysis in this patient. So we thought, why don't we see the actual organism, if there is any change or what are those? And this is the first study to our knowledge to have looked at the intestinal dysbiosis in chronic pancreatitis using next generation sequencing. So what we saw was, these are the three different groups. There was significantly different organisms or profile of the bacteria between the healthy controls, patients with chronic pancreatitis without diabetes and with diabetes. And if we see here, of the many species, this important species was progressively reducing in the abundance as the disease progression increased from diabetes to non-diabetes. It's called the Faecalibacterium prosnitzi, and it is one of an important butyrate producer in the intestine, which is responsible for maintenance of the gut barrier integrity. And then when we looked at the functional parameters, what are these genes doing? What turned out that these were producing lots of lipopolysaccharide. These are the lipopolysaccharide pathways that are enriched within the intestine. And then we looked at the plasma endotoxins, which is nothing but lipopolysaccharides. So there was a parallel increase in the lipopolysaccharide or endotoxin in the plasma also. And interestingly, there was a significant negative correlation of Faecalibacterium prosnitzi and the plasma endotoxin, which means that if the Faecalibacterium prosnitzi is coming down, plasma endotoxin increases, probably because of lack of the gut barrier. And then this plasma endotoxin was significantly positively, strongly positively correlated to the blood glucose level. So this shows that loss of Faecalibacterium prosnitzi is most likely causing gut bacterial dysbiosis, increase in LPS pathway, and LPS is known to produce beta cell dysfunction. That has been proven many years back by different workers. And then we again qualified this further, showing that the dysbiosis in type 3C diabetes or diabetes related to chronic pancreatitis was significantly different compared to type 1 and type 2 diabetes. This is the different bacterial profile with very few common organisms between the three types of diabetes. So this kind of qualifies that in chronic pancreatitis, at least there is gut bacterial dysbiosis, which could, I'll skip this, which could lead to progression of the disease, including development of or progression to diabetes. So the other important thing is it's not just important to look at microbiome alone, because microbiome won't work by itself. It will work through metabolites. So it's extremely important to see the metabolites in this patient, and it's a very good thing that most of these microbiome studies that are published currently has also a metabolomic component included, which is very important. And in this, after that first study, we again progressed to look the whole thing in a bigger number of patients. We have been able to replicate the results in the microbiome, and we also looked at the metabolites. And these are complex network analysis. I'll not go into the detail, but the final result of the metabolomic studies are, there is a significant positive correlation of the amino acid alanine, which is known to produce insulin secretion with these good organisms. And same thing happened with myo-inositol. So in this situation, if the patient has low alanine and few of the other microbial metabolites, that might lead to development of, or increase the risk of development of diabetes in these patients. So now coming back to the chicken egg story, here this was what I was telling. It is not necessarily a one-way traffic. So in chronic pancreatitis, because of impaired fat digestion, exocrine insufficiency, there will be undigested fat in the intestine. And that undigested fat is causing the microbial dysbiosis, which in turn cause gut barrier dysfunction, plasma endotoxemia, and finally it can lead to progression of the disease to diabetes. So again, it's a two-way process, and I think same kind of events can happen with many other diseases also. So again, quickly going through IBD, there has been several studies which shows that IBD and microbial dysbiosis are very closely linked, and this is a very current study, a recent study that's shown the relationship of the dysbiosis and the metabolites. So again, if you see here, these are the controls, the blue dot are the controls, these are the ulcerative colitis and Crohn's disease. And both diagrams, if you see, there is clustering of the metabolites and clustering of the microbiota, the bacteria. And then again, this is a busy slide, I won't take you through the details, but if you see here, these are the organisms and these are the metabolites, and there was strong correlation. In fact, they could pick a few organisms who are strongly correlated to specific metabolites, indicating that those metabolomic changes probably is contributing to the pathogenesis of the disease. Same thing with irritable bowel syndrome. Again here, the different subtypes, constipation predominant, diarrhea predominant, mixed, undefined. Again, there was significantly higher amount of dysbiotic organisms compared to the commensals, and again there is a significant change. So these are the healthy control metabolites, and these are the IBS patient metabolites. There is a significant difference. Then again, in liver disease, fatty liver disease, there are several studies that have shown that there is microbial dysbiosis that has been shown all over the years. But this is a very interesting study that was published, I think, this year, February, in Nature Medicine. So what they showed was that even in the NAFLD patients, it's alcohol that is probably causing progression of NAFLD. And from where does the alcohol come from? So there they could show a significant alteration in the dysbiosis and more of alcohol-producing bacteria within the gut. And this alcohol was translocating into the portal vein, and that was leading to the progression of our development of NAFLD. And this is a beautiful correlation matrix that shows this lactobacillus abundance was positively or strongly correlated with postprandial ethanol in the portal vein. So even if we talk about these are NAFLD, non-alcoholic, still alcohol may play a role in this patient. So let's quickly go to some of the microbiome-directed interventions. So how can that be done? There has been lots of studies on probiotics, fecal microbial transplantation, different augmentation strategies. But I think still, even now, in the context of GI disease, the most important would be the general measures of diet and lifestyle. So it's very important, again, everyone knows this do not need explanation. We should have more of a healthy or vegan-based diet, which has been shown to maintain a good gut microbial diversity. So that has to be consumed. Junk food or fast food, why should we avoid it? How does it lead to microbial dysbiosis. These are all processed food, and processed food contains lots of emulsifiers and preservatives, and it has been shown in several papers in Nature and Science that these preservatives and emulsifiers can cause gut microbial dysbiosis. And this is today's lifestyle of a changing pattern of diet, and which is to a large extent causing this. Antibiotics, again, it's a common habit of both non-doctors, doctors, everyone to take antibiotics. Anyone has some sneezing or some sore throat, they'll run to the pharmacy and pop a few antibiotics. But what do these antibiotics cause? Again, if we see the processed food, the broiler chickens and all other processed food, they have lots of antibiotics. So basically, in those, we are popping antibiotics rather than those chicken. So to maintain those, and this is a very nice study published from Delhi, I think, last year. So they could show lots of antibiotics within the meat of these animals. So processed food, besides containing emulsifiers and preservatives, also contain lots of antibiotics. And this is worrisome. Like if we see, this was the pattern of antibiotic use in the last 10 years. This is India, up to 40 to 80-fold percent increase in the antibiotic use over the years. Significantly high proportion of patients have resistance to E. coli. And this is how the antibiotics will cause resistance. There is something called horizontal gene transfer. If I have lots of antibiotic, I have resistance that may be transmitted to the whole community, not only in my own body. So that is horizontal gene transfer. And this is the prediction, like by 2050, 5 million people of Asia will die because of antibiotic resistance. So it's very important for us, it's our responsibility to spread the message or make sure that antibiotics are not used irrationally. So can diet make a difference? So again, I have been talking, all of you know about this, that diet is important, but then it's not about eating good food. The dietary content is important, but it's also about food matrix interactions. What kind of food do you take? What is the combination of food that you take in a particular meal? Timing of intake and circadian rhythm is a very important thing. We often do not realize this, but the whole body's suprachiasmatic nucleus that regulates the several physiological function of the body, including digestion, secretion of the pancreatic or digestive enzymes, and that modulates the microbiome. So if we do not follow the biological rhythm, which is very common with today's lifestyle, like we ourselves cannot follow our timing of sleep and waking. So that affects the circadian rhythm, and that affects the microbiome by itself. And on top of that, if we are into the bad habits, bad lifestyle, bad food, that will augment the whole thing. And again, there are several diets that have been described. One of the best diet is Mediterranean diet, which has been shown to improve all the good species of the microbiome. And the good thing is the several South Indian diet recipes have several components that are similar to the Mediterranean diet. So South Indian food could mimic the Mediterranean diet and maintain a good microbial health in the intestine. So now what about the microbial intervention? So in liver disease, in the context of liver disease, several studies have shown variable results with probiotics. Fecal microbial transplantation has been shown to prevent disease, shown to prevent decompensation across various studies from India, from the West. Jasmohan Bajaj has lots of work in that. But the thing is, there are several barriers to that, because most of these studies have shown heterogeneous results. The study designs were heterogeneous, so there is no standardization of the formulae. So these are costly, and we do not know the long-term consequences. So more data are required before we can write a strong prescription of gut microbial manipulation for liver diseases. Similarly, there are other microbial augmentation strategies like analogs of FXR receptors. Again, dietary measures, high protein diet, high fermented milk, periodontal therapy, because it has been shown cardiovascular disease has been linked to altered oral microbiome, altered dental microbiome. So, but these are all, many of them are still in trial, experimental therapy. Again, even though we talk about diet, we do not know what is the best and standard diet. Cultural differences could play a role in this heterogeneity, there is no harmonization of diet in microbial studies. So all these are hurdles that needs to be crossed before we can actually prescribe these modalities to these patients. Again, in IBD, in Crohn's disease, there are no beneficial or positive results from microbial or fecal microbial transplantation. Some benefit has been shown in ulcerative colitis, and probably the best result can be obtained by using multi-donor stool samples and something called super donor. If you see here in this patient, the donor has the highest alpha diversity. Again, I don't have the time to discuss alpha diversity and the technical aspects we can discuss later. So that is a super donor who has the maximum variety of organism. So if a patient is getting stool from such mixture of donors, multi-donor or multiple super donor, the results are expected to be better. Now, if we go to FMT in irritable bowel syndrome, this is again very recent meta-analysis, 7 RCTs, nearly 500 patients. So there was no association of FMT with improvement in the global symptoms at 3 and 12 months. Of course, there was some improvement in the quality of life, but what the patient would be more important for the patient would be the global symptoms. And the quality of the evidence of these studies was very low, and there was several heterogeneity. So again, it becomes difficult to say or prescribe FMT for patients with IBD. Now, what about probiotics? Again, IBD is a very common indication for the use of probiotics. It's very commonly used all across the places. So again, this is a very recent meta-analysis of 43 RCTs of over 5,000 patients. So here, the earlier studies, earlier meta-analysis that were done like 3-4 years back did not show much of a benefit. But in this, if we see the global symptom scores, when it was evaluated, there is an organism called Bacillus coagulans who had the maximum benefit, followed by Butyricum, followed by Bifidobacterium longum. Similarly, abdominal pain scores was benefited best with coagulans, followed by Saccharomyces cerevisiae. Bloating score, again, coagulum stands first. Straining scores, again, coagulans stands first. So in the context of IBS, possibly probiotics containing Bacillus coagulans could be of benefit, but again, these studies have come from the West. Indian microbiota is different, so we need more studies from our patients. So are we there yet in the context of probiotics in GI disease? Again, the problem of probiotics is they use only selected microbiome. They do not give you the whole ecology to the patient, and what we need is the whole ecology. The microbiota is an ecology. And there has to be lots of crosstalk between the different species. But the problem is the best organism which one need to have, like Faecalibacterium, Roseburia, Rubinococcus, Prevotella, which is the most common in India, they are unculturable. So a probiotic capsule cannot have those organisms. So this is a big hurdle. So we do not know how the effect of the resident microbiota. When we give a probiotic capsule, what happens to the resident microbiota? We do not know for how long the given prescribed probiotic stays or harbors in the intestine. And does a single probiotic fit all? Probably not. And we need better quality RCTs before using probiotics widely in the GI disease. And the other problem is probiotic that has been shown to be beneficial in the studies are custom made for the study. But what happens in the real life? Probiotics travel a long way from production to the consumption, and in between they go through lots of processing, packaging, storage, and even in the intestine they have to go through a wide range of intestinal adverse milieu, the pH, wide range of pH, and so we are not sure the capsule that comes from the pharmacy or the industry, how much actually reaches or how many bacteria actually reaches the intestine to give an adequate effect. So that quality control measures has to be maintained. We do not have that any yet. And FMT, again, in the Indian context, I think this is my last but one slide, yeah. all FMT studies are from the West, and we know now that the bacterial profile or the fungome profile in the West and India are very much different. There have been studies, Ramakrishnan sir has done many from India, we had done some studies. So the microbial profile is very different. So will data from West be applicable to India? Will combination modality be more beneficial rather than giving a fecal microbial transplantation? Is combination of diet, probiotic, because all of them are supposed to augment the microbiome. Who is an ideal donor? In the West, people are mostly taking non-vegetarian diet. Majority of the Indians are vegetarian, and even though they take, many of them take non-veg diet, but they are not habitual non-vegetarians. They have periodically. So who is an ideal donor in the Indian context? And again, use of antibiotic is very rampant in India, as already said. So if someone wants to donate, still how long he has to wait after taking the antibiotic? Because antibiotic has been shown to cause dysbiosis, which may last up to 2 years or more. Which route will be better for a specific disease? Like for example, ulcerative colitis, where mostly the large intestine is involved, obviously the colonic route is better. But for liver diseases, where the small intestinal bacteria is more dysbiosis is more predominant, where the portal vein is involved, is it the oral or upper GI route better, or the colonic? So all these are questions that has to be answered in the Indian context. Unfortunately, do not have that. But one good thing that happened is recently this paper was published by Vineet Ahuja and his group, where they had looked at combination of fecal microbial transplantation with anti-inflammatory diet, and they compared it with standard medical care. So what they observed at 8 week was that the patients who were getting the FMT plus anti-inflammatory diet had a significant clinical response with an odds ratio of 4.5, 3.5, nearly 3-point improvement or higher chance of remission, and in fact 6-fold higher deep remission compared to the standard diet. So this is probably a beginning of this kind of studies from India, and I think we should do more of these studies that would cater to our patients. And finally, the take-home message, ladies and gentlemen, is microbial dysbiosis in GI is real. Again, dysbiosis and disease interaction are more likely to be two-way, not a single-way traffic. Like one can lead to the other, and the other can contribute to the other. But then there's limited utility of FMT on GI disease at this point, except for ulcerative colitis, where data is strong. Again, limited utility of probiotics, and I feel personally diet and lifestyle modification still remains effective and durable for these diseases and in general to maintain a good microbial diversity. So finally, I'd like to thank and happy to take questions.
Thank you, Dr. Talukdar, for a wonderful lecture and a complicated topic. I got a one question.
Yeah.
You said this change reverse, can be up to 2 years.
Which
the
one?
Change in microbiome following antibiotics.
Yeah.
So suppose if we keep on taking antibiotics, this is going to be a continuous process.
Yes.
So what is the relevance of this change in relation to the development of cancer?
Two things. One, if this change keep on happening, because again colorectal cancers are associated strongly with altered microbiome. So even though I said this happens till 2 years, but the study was done till 2 years. We don't know what happens beyond 2 years. And if that antibiotic intake is repeatedly happening, so that will become a recurrent process, and at some point there will be irreversibility. And that would lead to the higher risk of cancer. And I would not say the microbiome by itself will cause cancer. There will be, because all of us take antibiotic, but all of us do not get cancer. So there are other risk factors. So the effect of the other risk factors will be augmented by this dysbiosis. So that's how it would happen.
Maybe a compounding factor.
Yeah.
Thank you. This presentation is open for discussion. Any questions or comments?
Okay, so rifaximin seem to work mainly in the small intestine, And that can actually cause some, so even though if we give rifaximin for SIBO in the small intestine, some change may happen in the large intestine, which may not be good for the thing. So if antibiotics can be avoided, it should be best avoided. But if it cannot be avoided, of course, we have to give after that, I mean, many people do that, like give a course of probiotic. We do not have hard data. I don't know, sir, maybe knowing that it will restore that, but with a hope that it may restore. Short course of probiotic can be given, but we don't have hard data for that to prove or disprove.
Any comments, sir?
Sir wants to say.
So I wonder why the probiotics have always focused on lactobacilli, bifidobacteria, and possibly Saccharomyces.
Yeah.
You've showed, for instance, that Faecalibacterium prosnitzi has probable very good beneficial effects.
Yeah.
Why would somebody not develop Faecalibacterium as a probiotic?
So the first thing, why more concentration is given on lactobacillus, those are culturable bacteria, so it's easy to make them or, I mean, develop into probiotics. This Faecalibacterium, roseburia, those are unculturable. But now there are few studies going on in US where they're trying to make them culturable. So they are trying to tweak their some of their features, and so if that happens, probably we might have capsules of Faecalibacterium in the future. Right now that is the status. But of course we need more of those, Faecalibacterium, Ruminococcus, Prevotella. So.
And probably that the ability to survive or the ability to live and survive is also the reason why the Bacillus coagulans, which also is called Lactobacillus sporogenus, is widely used.
Right.
Originally,
it's Lactobacillus spore.
When I was a child, I remember that all antibiotics came along with Lactobacillus sporogenus.
Okay.
I don't see a lot of it being used now.
But won't that kill the organism also, the antibiotic, when they are in combination, or?
No. These lactobacilli actually have intrinsic resistance.
Okay.
So it is, they don't have the molecular
molecules
targets
for
the antibiotic.
Yeah.
Any other question? If there are no questions, we'll wind up this session. Thank you very much.
Thank you. Thank you.
Next speaker is very own Professor Epen from CMC. He has been a professor at CMC since 2003 in the hepatology department. He is a clinician, also did administrative duties for 5 years at CMC. Must have been challenging. And also publishes a lot of papers. According to CV, 10 to 12 or 15, averaging 10 to 12 per year, which is very commendable. And of course, he is a member of our editorial board for our journal, also the Indian Journal of Gastroenterology and Hepatology International. So he's going to be talking on acute on chronic liver failure, standardizing our approach. Looking forward to your talk.
Thank you to Dr. Rama and Dr. Ubal for inviting me for this talk. So first of all, at the second birthday celebration of a journal, I want to highlight that it has had already an effect on the public services in our state, and the TNISG guidelines which came out on managing rodenticide poisoning in our state led to, within 6 weeks of implementation, and in the course of this year, 6 government medical college hospitals have installed centrifugal plex machines. This Monday was one such audit which happened, and in Madurai Rajaji Medical College in the last 3 months, 35 patients underwent plex for rodenticide poisoning. So it's very rapidly the impact of the journal is being seen in our public systems. So in ACLF, the points I would like to cover are about definition and classifying disease severity and treatment strategies on looking at etiology primarily of the acute insult to the liver and how increasingly Plex plus low-dose steroid may help in dousing the fire caused by the overactive innate immune response and the need for liver transplant, almost like an urgent transplant need in some of these patients with more advanced disease severity. So there are two popular definitions which are used. One is the APASL definition, which was the original definition proposed for ACLF, and then the European EASL-CLIF definition. Both of them have an acute liver insult, underlying chronic liver disease, and a high 28-day mortality. However, there are differences. The APASL definition focuses more on liver failure, while the EASL-CLIF definition focuses more on the extrahepatic organ failures. There are 6 organ failures in the EASL-CLIF, and they are primarily from the SOFA organ failure scores: kidney, liver, coagulation, CVS, respiratory, and CNS. But as you can see, there are many differences. For example, the bilirubin level is cutoff is 5 or more for liver failure in APASL, while it's 12 or more in EASL. Similarly, the INR, there are differences as well. I see that APASL is the one which is easier to make the diagnosis of ACLF. The classifying the disease severity, however, is more easier to do it by the EASL-CLIF, at least conceptually, where it's number of organ failures and the type of organ failure. But to do it really is not so easy. So it's more for a research tool, I must say. In real life, it's not, both are cumbersome. The disease categorization by EASL-CLIF, while for APASL, it includes the need for plasma lactate, which is not necessarily done in all patients who are not in ICU. There's a challenge there as well. So some differences between the APASL and the EASL score. The APASL ACLF, by definition, picks up people who are earlier in the disease severity, while the EASL ACLF, as I mentioned, focuses more on extrahepatic organ failures. Now, this study from Europe looked at more than 1,000 patients who were hospitalized with cirrhosis, and they showed that those who met the criteria for ACLF by the EASL-CLIF had a high 28-day death rate, while those who did not have ACLF but were hospitalized, admitted with cirrhosis, the death rate was only 2%. So when the definition of EASL, when the definition of ACLF comes up in hospitalized patients with cirrhosis, the 28-day mortality increases very significantly. Now, my talk is on how to manage these patients. So this is the APASL guidelines on this, which Dr. Sareen has authored, primarily focus on 3 areas. One is on identifying an acute insult and how do we treat them appropriately. 2 is mainly about support therapies, for which, to me, increasingly it is plasma exchange. And thirdly is about liver transplantation. A similar proposal has come out from the European series. It's again mostly the same. It's about organ support, and patients who got more severe disease consider liver transplantation. Even more severe disease, it's termed as futile, and withdrawal of care is what is proposed. So my approach is, we should, in such a patient, ask ourselves, why is this particular patient so sick? And treat accordingly. I'm trying to identify what's making the patient more sick. So I'll be focusing on the acute insults etiology or cause and the correct treatment accordingly. Thinking about which patient where I would think about Plex, plasma exchange, and which patient is liver transplantation. So let me use that APASL, Dr. Sareen's that algorithm, and look at them one by one. So in the acute insult, the specific therapies I mentioned for alcohol, where steroids could be used. For hepatitis B is antivirals. Autoimmune hepatitis is steroids. And for a DILI to stop the offending drug and consider Plex, and Wilson's to consider Plex. The newer things which we are doing are these 2 I would like to highlight. In fulminant Wilson's, the drug of choice is trientine. In a person who's got very severely altered liver function, to give penicillamine is a challenge. Often we do not do. We think the patient may not tolerate that. That is not a problem with trientine. So trientine and zinc, trientine is now available in India, is the drug of choice. And we would also add on Plex plus low-dose steroids. Currently, I think we have crossed maybe 11 patients now with fulminant Wilson's where we have treated with this approach. In hepatitis B flare, let me take a few more minutes to explain this point. This is an area which currently is not treated appropriately, I feel, and we could save more lives in this uncommon scenario. So let me present this patient who came from Kerala in the last 2 months. 69-year-old gentleman had 1 month of jaundice and loss of appetite, initially vomiting for 5 days. In the 1 month has lost 10 kgs of weight. For the jaundice, he took now Ayurvedic medicine. And he's also a diabetic, had a bypass surgery for coronary arteries in the past. His LFT is on 15th of August. Bilirubin was 9, enzymes were more than 1000, INR 1.7. HPSAG negative, IgM core was positive, and DNA level was 49 lakhs. Ultrasound showed chronic liver disease, mild splenomegaly, mild ascites. He was started on tenofovir and lacilactone. After 4 days, that's his LFTs. After 3 weeks, he was not getting any better, so he had come over to Vellore. So when he came over on 6th of September, the bilirubin was 19. Enzymes have come down a bit, INR is 1.6. Here again the parameters are HPCG negative, IgM core is positive. After 3 weeks of tenofovir, the DNA level has come down to 103. His VW levels were elevated, up to 150 is a normal value for us. Ferritin was not elevated. Now, the fact how his disease has manifested so far is in line with this RCT from ILBS, where people with symptomatic acute hepatitis B were randomized to lamivudine or placebo. By doing that, there was reduction in the DNA level, but no significant difference in the biochemical or clinical improvement. So giving antiviral alone in a person with severe acute hepatitis B has not shown to be making a clinical difference, but for reducing the DNA level. So in that ground, in that situation, using the logic that it may be the overactive immune response which is affecting the liver and causing liver failure, this study from Japan has highlighted the use of using steroids in this scenario. And they concluded that steroid plus nucleoside analogs may be helpful in this scenario. So in this patient, we started 5 mg of prednisolone. Within 2 days, he wanted to get discharged. He said, I'm feeling good, I'm good. And he's come back now, last 2 weeks ago. The LFT is now almost normal. So this is an underutilized situation. It's not a common situation for us, but I have seen that this is underutilized. We are familiar with using antiviral, but we are not using the steroid in this scenario. We have a series of patients. There are more now. I only booked up these from an early analysis of patients who are more sick with hepatitis B and acute liver failure. These are people who are in grade 4 encephalopathy. I think three of the patients were on a ventilator, where increasingly we've used tenofovir, steroids plus plasma exchange. Only difference over time, we are now using a low-dose steroid with plasma exchange. So, and increasingly, plasma exchange is used for hepatitis B ACLF. This is a big problem in China, and this data set had 250 patients where they feel that it's starting to improve survival there. So I've just highlighted 2 areas in the acute insult where some newer ways how we are managing these patients are. Let me move on to what about liver transplantation in people with more severe grades of ACLF or more organ failures. Liver transplant is advocated. So this is a recent article, which is again from China, which looked at One is, what are the outcomes with after liver transplantation with hepatitis B-induced ACLF? And they compared earlier reports where there were no liver transplants done. And clearly the survival is much better by liver transplantation compared to no transplant in different grades of liver severity. For example, in the last row, patients who had grade 3 ACLF had, with no liver transplantation, a 3-month survival of 5 to 10%. So 90% of patients had died. With liver transplant, the survival is markedly better. This particular study also compared E-cell versus APASL ACLF definition and disease severity classification. And they concluded that it was equally good in categorizing disease severity with transplant outcomes. Yet another study from Europe, we looked at liver transplant in ACLF, and the 1-year survival probability after liver transplantation was 81%. This was the only cadaveric transplant program. From the time of listing, the liver transplant happened with a median of within 8 days. So it's almost like supra-urgent listing, but it's not supra-urgent listing, but it's urgent listing. It looks like that. So this is a graphical abstract of the same study. The improvement in survival pre-liver transplant listing to those who underwent transplant. Everyone who was listed did not have transplant. We can see it is in all grades of severity. Here they looked at number of organ failures are shown in the different graphs. But when there are 3 or 4 organs failing, the survival benefit is even more stark, is even better. So clearly, liver transplant is a good option. The benefits are evident from these studies that in patients with ACLF, with more severe grades of disease severity, urgent transplant is a good option. However, increasingly, Plex is winning the battle. So let me talk about that now. So this is one case description which we had put out in our journal, in GHEP journal, the patient with very severe alcoholic hepatitis who had a bilirubin of 39 and a MEL score of 42 and underwent Plex on June 19th to onwards for three days and was on a low dose of prednisolone 10 mg till July 9th and has done remarkably well with this therapy. We could show last year that by this analysis that low volume plasma exchange and low dose steroids improved marginally the survival over 1 year in patients with severe alcoholic hepatitis, all of whom met the APASL ACLF definition. Now, this full manuscript is almost ready. We'll be soon sending it for publication. When we reanalyze the data set with more number of patients with severe alcoholic hepatitis, in fact, all had very severe alcoholic hepatitis by definition. When the centrifugal type of plasma exchange was done, was analyzed, the survival is markedly better compared to the membrane type of plasma exchange or standard medical therapy. When we look at, we have an interest in BWF, which is a macromolecule, which is almost like an inflammatory debris which is floating around. In patients who survive after plasma exchange, the serial BW levels come down compared to those who did not survive. And we could also document that in the plasma that we discarded from the patients, there is, including all of the proteins, BW is also coming out in that plasma. These are studies from India on the use of Plex in ACLF. The first study is from ILBS, which looked at the APASL ARC consortium. The other 2 are from PGH Chandigarh and AIMS Delhi. All of them are starting to now report increased survival with plasma exchange in ACLF patients. So increasingly, more and more centers all over India are doing Plex, and data is starting to support this therapy. So because of this dire need and for the fact that at CMC we do not have a live donor program, the number of liver transplants done per year in cadaveric program is at the bottom. This year there were 11 such patients. So increasingly, we are doing plasma exchange for different liver diseases, and that's the numbers till October. So it's almost, usually it's 2 patients per week are getting done. And I think now we have reached 380 odd patients. 2 big syndromes, of which ACLF is almost half the number of patients. And 106 of those ACLF patients are due to alcohol etiology. So let me last 5 minutes show some cartoons. So it's good to figure out what is this disease mechanism and how does this treatment help. So these are all from Asterix and Obelix. So which is the innate immune response, which is adaptive immune response? So innate immune response are these uncivilized characters. So they'll bash up anyone. They are soldiers which will act very fast. They are rapid action force. They either hit the enemy or they eat them up. When they eat them up, it's called phagocytosis. On the other hand, the adaptive immune response are more civilized characters, but they take time to respond, and they have to be exposed to the microbial antigen, and then they work. Some of the innate immune cells are too big to be moved around. It's like this big cannons in the fort in Vellore. So the macrophages, the Kupffer cells in the liver, are big cells. When they eat, they become even bigger tummies. You can't move them up. So the maximum number of macrophages in the tissue are in the liver in the body. They are kept at location, and they are called the Kupffer cells. 80 to 90% of the body's macrophages are in the liver. And the terms that we use for the host response when an enemy comes are also fairly sort of similar. So the immune response is the host response to kill an enemy, probably, while the inflammatory response, the host response to repair an injury, and sepsis by definition is dysregulated host response to infections. As you can see, they are sort of almost overlapping quite a bit. So overactive adaptive immune response, that civilized characters, example is autoimmune hepatitis. The treatment is high-dose steroids. We give 0.5 to 1 mg per kg per day. While syndromes of ACLF, acute liver failure, severe alcoholic hepatitis, or any other etiology of ACLF, ALF, etc., are all syndromes of overactive innate immune response. Increasingly looks that they like low-dose steroid. That's the sense it appears is going in that direction. As I mentioned, it's now very well known that if you want to recognize overactive innate immune response, the clinical diagnosis you have to make is ACLF. If I make ACLF definition, that means this patient has got overactive innate immune response. Now, the patient with an inflamed joint knows very clearly my joint is inflamed. The doctor also knows it. And there are these 5 classical signs of pain, warmth, redness, swelling, and loss of function. We know that ACLF has got severe inflammation, both local and systemic. But I was trying to put these 5 signs of inflammation. Pain, ACLF patient, no. Warmth, I asked the surgeon when they operate, is the liver warm? Doesn't sound like it. No. Is it red? The surgeon says no, the liver doesn't look red. In fact, in ALF, for example, in acute fatty liver pregnancy, it's also called yellow atrophy. It's not red, it may become yellow. Swollen, maybe not. Loss of function, yes. So it is difficult to initially think it's inflammation. We have to train ourselves to say ACLF is inflammation. Lastly, pollution in the liver sinusoids causes traffic jam. This is the theory of ALF, ACLF. So, 9 o'clock in the morning, the road in front is like this. Our idea of using plasma exchange low-dose steroid is to make it a bit like this. So I'm trying to explain our understanding how Plex works as well. So in this war which goes on, a lot of debris accumulates as well in the war. and that's accumulating in this microcirculation. So smoke plus fog is called smog. So in plasma exchange, we're removing only the fluid and not the cells. And it seems to be improving survival. So it's telling us something in that mechanism. Maybe the low-dose steroids are reducing inflammation, and the number of cars on the road, and maybe the number of swollen cells on the side of the road, etc., which are how the Kupffer cells, etc., would be like that. And material removed in the fluid, which is not the cells, only the fluid, can either be soluble. One example is macromolecules like VWF, or insoluble, or particulate material, for example, microvesicles which are breaking off from blood cells, hepatocytes, or endothelial cells. So the last two slides. So then which patient with liver disease do we select for Plex and low-dose steroid? So one is there's an organ failure, which is ACLF, ALF, or acute liver injury. And two is we have got clinical recognition of increased innate immune response or reticular endothelial activation. That means I'm making a diagnosis of ACLF or ALF, as well as blood test to back this up, which is VWF, as well as ferritin. In COVID, we were all testing ferritin. Ferritin is an indication of macrophage activation. It's part of the MAS criteria. So we are saying it is innate immune response. The RE system is intimately localized anatomically in the liver sinusoid. The fenestrated endothelial cells are seen there, which when activated release VWF. And these are the reticulated appearance of the Kupffer cell, the macrophage, which is seen on an electron microscope. And that's what we are recognizing by these tests. So this is acknowledging, and to avoiding plagiarism, I'm acknowledging Obelix and Asterix's author as well. Thank you.
So being a hepatologist, I'll start the ball rolling. I see that you moved from Nemo to Asterix of late. I've seen your Nemo slides. Two questions, Epan, and then I'll throw to the audience. One is about the use of steroids. Not all centers use steroids as part of the Plex regime. So I know you have your own theory, but have you tried Plex without steroids, and are you getting the same results? That's the first question.
Yeah. Thank you again. So initially we were not giving steroids. But so the very first patient when we did Plex was done by our neurologist. The patient had a phenytoin-induced DILI, was on a ventilator, and got extubated after 3 days after Plex. That's when we heard something called Plex. After patient number 10 or so, we started going into severe alcoholic hepatitis. The first 3 patients improved with plasma exchange, but they all left the ward dead. When we stopped Plex, all the numbers went above the admitting values. Let's say bilirubin was 40, became 30, became 45, as an example. That's when we started using preemptive low-dose steroid. We're calling it preemptive steroid therapy. That phenomenon stopped. That rebound did not happen any longer. So then we did not try it out any longer. We kept it like that. By patient 30 or so, we heard there's something called rat poison. Till then I did not have any much clue about it. Then the question is, should we use that rat poison, the same logic for steroid? So initially we were not giving, but we just made a policy change on that. So my answer is there's no grounds for that, but our experience with alcohol ACLF, surely low-dose steroid works very well.
Because many centers use Plex without steroids, and they are also showing positive results. That's why
Yes,
I was asking.
surely. For rat poison, we also have patients where we did not give steroid, but as a protocol, we are giving everyone steroid. We find it's okay, it's all right.
And one more is indication for Plex in ACLF. If you use Apacil, then you'll be using it on patients who are not that sick. If you use Easel, then do you just reserve it for grade of ACLF like 2, 3, or you would use it on all 3? And do you use bilirubin cutoff, or should we use VWF as a marker in the future?
Yeah, thank you. These are all evolving field only. I do not know the answers. But as I was preparing for this talk, I saw the European liver transplants done. 25% of the patients were done for ACLF grade 1. So when we're saying is, are we doing plex too early? Even liver transplant being done early. But that's the situation is like that only. I feel the window is even earlier. So in the ESL ACLF, there was one group called no ACLF. It's confusing. It's under ACLF, but no ACLF. I think that's where the window is. So we have to catch that window. Looks like in severe alcoholic hepatitis, the disease is such that the patient is declaring it. When the patient comes, the MRO comes and tells us, there's one sick patient standing there. Everyone knows that person is sick. But we still have a window there. Every disease doesn't offer that in this, I think. So for some reason, severe alcoholic hepatitis gives us a nice window. So I am thinking more and more we should catch it earlier because it's a well-tolerated therapy. Once you get the hang of it, it's nice. So I would even try to do it even earlier, but I did not know.
Okay, thank you. Anybody from the audience?
It's a novel thing. Centrifugal. We normally use membrane. You say centrifugal is slightly superior.
Okay, thank you, Venkat. So there are two types. So blood has got plasma, the fluid component, and the blood cells in it. So when we donate blood in the blood bank, what is done is the blood is put in a centrifuge, and when they do like that, centrifuge it, by density, there will be plasma on the top, buffy coat, and then the RBCs. So then that's how the separation is done. The same process, same machine is used for this centrifugal plex. While for membrane, normally for dialysis, the blood is forced through a membrane filter in which all the cells remain this side of the filter and the fluid comes on that side. So the flow rate needed to push the blood through into a membrane is a higher flow rate. For example, it will be 100 to 150 ml per minute. While for centrifugal plex, anyway is going to come out into one centrifuge and then only it gets spun. So we can go as low as 10 ml per minute. Usually we do 20 to 30 ml per minute. So that's the difference now. It's our experience, and even LVK from PSG was telling me that often with membrane, by the time the procedure is over, some patients are ending up on dopamine or noradrenaline. So they are getting hypotensing. With centrifugal, that's not happening. It's like when Mercedes-Benz. It goes very smoothly. So we think that the hemodynamic fluxes are much less with centrifugal. That is probably impacting survival. In this situation where the endothelium in the microcirculation is all starting to flake off inside the liver, any hemodynamic flux seems to be making a difference. That's our hypothesis. And yeah, that's right. However, right now, all over India, there is membrane dialysis facility available. We don't need to invest in centrifugal. So I think wherever it's available, it's fine to use membrane. But increasingly, it may be the centrifugal may start happening. But we only have the data with severe alcoholic hepatitis. Whether it applies to rodenticide poisoning, for example, we do not know. And the National Health Mission TAI program is providing centrifugal plex machines, which are costlier for the 6 colleges so far in government medical college. And increasingly, each district headquarters will get that, is what the hope is.
Ganesh? 2 observations. I need your response on that. Our experience with the plex is not very great, but we've used it on some patients. Patient number 1 is a severe alcohol hepatitis. Bilirubin kept rising. We were not sure whether he had sepsis or not. Cultures were negative, so we went to go ahead with that. Like you said, his bilirubin came down, but we were not sure whether we should do continuous plex for 3 days or do it on alternate day or once in 2 days. There was no clear protocol on that. But then after the 3rd plex, a lot of logistic issues occurred, and then he was not willing to continue on that. The bilirubin overshot from 35 to 45, and we lost the patient. Number 2 was DILI-related liver injury, stanzol, where he had a rise in bilirubin, but fairly preserved liver functions. His bilirubin went up to 45. Enzymes are not very high. There was no cholestasis. But he had severe fatigue and all that. Since it was not coming down, Again, we used Plex in this condition. We used it for 2 cycles. We couldn't convince him for a 3rd cycle. It came down to 30, but again overshot to 45. But since he was okay, not willing to stay back, he went home. He came back after 2 weeks. Surprisingly, his bilirubin came down to 12. Now, what is the reason for this? And number 2, what is the protocol? How much of Plex we should do? Because all of these things are logistic issues in the corporate sector. It becomes very difficult to get so much of albumin, so much of platelet, and etc. etc.
So, thank you, Ganesh. Our protocol has evolved over time. Initially, we were doing alternate daily. Now we move to daily. So daily, once daily for 3 days. That's what we're doing now. There's been a study from Poland, which I'm aware of, which was published 3 years ago, where they did once monthly for 6 months for patients with PBC. So there are different protocols possible. So they did once monthly for 6 months for PBC in Poland some 3 years ago. You can do it different ways. 2 is, it's good to have success. So I would be initially, in any center, be selfish. If I want to start a liver transplant program in a hospital, first 3 patients, at least 2 should survive. Otherwise, unlikely, the hospital manager will say, Napa. So similarly, same applies here as well, in Plex as well. So if you have, otherwise, you are also, the whole team also is not, so that's one point to keep in mind. Keeping all that in mind, we started with the sickest patients initially, because we were unsure how it would go. So normally bilirubin would be 30, 40, 50, in that range only. That's how we started with, to say. Not every patient survived here as well. The graph looks different, but remember, 40% still have died. It's not that, but increasingly people are surviving. So these are my general comments on that. But you have to do more. Unless you do 20, how do you know that your first 2 may not necessarily? But at the same time, I would look for good candidates, which I should do. That's what I would say.
This guy who went home with 45, came back with a 12. So what was the...
So I see that this is something like a critical care treatment. And I see, for example, the pediatric intensive chief at Vellore. He views it like giving some oxygen supplementation to a patient. There's only one supplemental therapy, really, at the end of it. We are only trying to help the whole process to go in the correct direction. That's why all these cartoons make a difference. What is this disease mechanism and how is it helping? It's still work in progress. No one knows as yet, to say.
Dr. Joy?
Joy's PhD has been on Plex.
Thank you, sir. Thank you. I mean, the Plex-related things, actually, they're evolving, I agree. But the centrifugal-related, the few comments, and then I have few questions to you, sir. The comments-wise, the centrifugal always, our experience-wise, better than the membranous, no doubt. The second thing, every day we have to do the Plex, actually, day 1, day 2 consecutively. Maximum, the bilirubin level will come to close to 10. We can't reduce lesser than 10 using the Plex in any ACLF or ALF. But in cholestatic jaundice, different. It is bringing down less than, because we don't know the reason. That's all the experience. And whenever the Plex, after the consecutive days reduction, still the bilirubin goes high, that we have to take a sign of liver cell failure. We have to try to inform the family and the patients they are going for the complete liver cell failure. That's the practice. And the questions to use are actually regarding the using the steroid, as Dr. Murugan asked, actually quite interesting, using the low dose steroid in acute Wilson and acute hepatitis B, because I mean acute Wilson, obviously the patients are more, but the acute hepatitis B related, the liver transplant, even in the last, I mean, the overall, whatever, I think even more than 1,500 transplant, we have done only 1. So acute Hep B flare is different. We are seeing ACLF different, but the acute Hep B alone related ALF per se is in our population very low, not only in our, in worldwide. Because that's why in acute hepatitis B, we are not treating with oral antiviral drugs. Usually the patients slowly they recover. And even if they, we won't look into the viral load also in acute hepatitis B causing ALF. But if they goes to cholestasis also, and the patient conscious level, everything mostly fine. ACLF, if we think, okay, very high bilirubin, we can do, because the steroid related, the studies are more there in B virus reactivation, and compare with that, I mean, so many studies are there. Even total HB core antibody positive, steroid, that will increase the flare. So that is, I need whether better, I mean, as the study, I mean, as your observation from CMC Vellore and other thing, we are very much excited to learn from more. So what is the, without steroid, and as Dr. Murugan, with the steroid, the better RCT trial comes from there, and it is a good, I mean, everyone will follow it up. And regarding the acute Wilson disease also, we need, I mean, just the, I mean, trientine, okay, fine. But adding the steroid, I mean, we need a better, I mean, the study from the CMC Vellore, because nowadays we are doing the liver transplant or plex for the acute Wilson. So without transplant, we are seeing the patients are coming out very well, even the acute Wilson using the plex. But trientine plus low dose steroid, without plex, with plex also, it will give a more idea to all of us. Thank you.
Thank you. Thank you, Joy. As I mentioned, he has done his PhD on plex. So he is a very experienced person in this area, and evidently has thought through all these. Now, both these are uncommon scenarios in India at least. Hep B is more common in China, so there are a lot of publications in China of Hep B ACLF. So let me tell you a story about the very first patient. Lady got married 4 months ago, came, history is 2 months pregnant, last 2 days unconscious. HPCG is positive. Enzymes were like acute hepatitis. Then later on, we checked the husband, he's HPCG positive. So it appears that she may have acquired hepatitis B recently, and she is now unconscious. So 3 days or 5 days, we gave tenofovir, mannitol, whatever we could think of it. No liver transplant, they're thinking. Then only we came across this article, and they used very high dose steroids. Methylprednisolone was very high dose. It's equivalent of giving 600 mg of steroids, or prednisolone. But the logic was, why is this patient sick and I'm giving antiviral and still not improving? So is there a component of overactive immune response? And there is enough in literature saying, yes, there is a component. Then are we giving the immunosuppressive therapy then? We are not. So I am not for giving it to the regular acute hepatitis B, no. But in a person who's got what is severe acute hepatitis B or any complication like this, there is a theoretical basis. But now we moved to giving low dose steroid. That's one difference, and we're doing it low dose steroid plus plex. So I'm comfortable with that move, I must say. But that is just our preliminary experience. We may have some 7, 8 patients only like this only on that. And we have to analyze that and present that to see. In Wilson's, the logic of steroid is I'm making a diagnosis of ALF or ACLF. In which case, to me, it is I'm diagnosing overactive innate immune response with an organ failure. For that syndrome, I am giving low dose steroid plus plex. That is the package. So that it's not for the copper toxicity, it is for this syndrome. Because syndrome to me now, as I showed, it is not following the 5 cardinal signs of inflammation. It's not. But I am telling myself, if it's ACLF or ALF, to me it's overactive innate immune response, this organ failure, this is the package. But it's again a hunch only. It's again only 10 patients is not enough to make a comment.
Okay, so we'll end with that. Any more questions? Okay, so last question. Yeah.
Are there patients in whom plex will not be offered? Like suppose grade 3, grade 2. Are there patients whom we say plex is not going to be useful, we are not going to offer it? And 2, steroids, I mean, how often do we give antibiotics along with this? I mean, is it the risk of sepsis? Do you routinely use antibiotics when you use this low dose?
Okay. So just as a preamble, when we do 400 patients, it's all done by students. When each new batch of students come, within 1 month, they'll come asking, shall we plex this patient? That means they are by then catching on what we are thinking as a plexible patient. as well as the contraindication. It's becoming picked up by them only. So it's with each new batch, I'm happy that people are able to catch on that information. So we put that into words in the world's first guidelines on plex in liver, that is the TNISG guidelines on rodenticide poisoning. The 2 small paragraphs on that. So the contraindication of plex which we have taken on are, suppose the person is already hypotensing and on NORAD. If I now take out more plasma, will the person hypotense further? Will I cause more harm? So we kept it as a contraindication, but again, we are starting to push it ourselves a bit. Or 2, if there is active sepsis now, then we are not doing it. But for these 2, thirdly, we kept us in an ACL situation, recent upper varicose bleed. The logic was, by removing VWF, which is a blood clotting protein, will we cause more bleeding to happen? Now, I think that's flawed logic, so we are more and more not considering that. So, but for these 2, any other patient we can do it for. That's what our current contraindications are. Antibiotics. These are a highly sepsis-prone scenario. So every patient is screened for infection. We do daily blood cultures, and we get an update on culture positivity by the hour. That's how the situations, facilities like that. And we give prophylactic IV antibiotic. If we think there's an infection tomorrow, we're stopping the plex tomorrow. But to know is infection or not is very difficult because the MAS criteria of sterile inflammation, there are 6 criteria. One of them is fever. So even fever per se is part of sterile inflammation. So to know whether it's septic or not, know whether the person is improving or worsening or not, by bilirubin level, for example, depends on which part of the LFT I'm looking at and whether you're an optimist or a pessimist. So it's very difficult to know. So there are challenges, but we have a very aggressive policy on antibiotics, and that's how we do not have a sepsis as a problem in this patient. Because if so, we stop it or we take some action accordingly.
Thank you. Thank you, Ipan. Great lecture, great discussion. Thank you.
On behalf of our society, I would like to thank Dr. Karthikeyan from SIM Chennai, Dr. Rupjyoti Talukdar from AAG Hyderabad, and Dr. Ipan, CMC Vellore for their excellent talks. Thank you, sirs. I would like to thank our chairpersons for having conducted the sessions well. Next, I would like to thank our patrons, teachers, senior and junior colleagues, postgraduates for their active participation. I would like to thank Force Pharma, Delvin Pharma, and Adlib Pharma for their academic participation. And then I would like to thank the hotel management for the excellent ambience. Thank you all.